The topic for discussion today is tumors of thyroid gland. Here we will be dealing with the various types of tumors, benign tumors and neoplastic tumors. The malignant tumors. However, the tumors of thyroid gland are usually uncommon cancers. Okay, they rarely occur. But among the endocrine neoplasms, thyroid neoplasms are one of the most commonest one that we encounter. However, thyroid neoplasms can also be sites of other primary cancers like sarcomas, etc. And they can also be the sites of metastatic lesions from lungs or from the breast cancer, etc. Even from these different regions also it could be a site of metastasis. However, tumors of the thyroid gland itself are not very common. Okay. However, we'll be dealing with various tumors of thyroid gland today, the benign and also your malignant tumors. Firstly, to classify grossly, there are again benign tumors and malignant tumors. In benign tumors, adenomas are the most common ones. In adenomas, we again have follicular adenomas and papillary adenomas. In malignant tumors, in malignant neoplasms, we have papillary carcinomas, we have follicular carcinomas, medullary carcinomas, anaplastic carcinomas we have, and we also have lymphomas, okay, of thyroid. We also have these kind of tumors again. Now, to go for benign tumors first, when we talk about benign tumors, as I said, adenomas are the most common benign tumors that we occur. Among these adenomas, follicular adenomas are the commonest one. And all these benign tumors of thyroid gland usually arise from your glandular epithelium. Okay, they arise from the glandular epithelium, and these tumors of this glandular epithelium are called as adenomas. Okay, all these adenomas have more more seen or more commonly seen in women, and age group is also like these are all true neoplasms, and age group, mid-age group, from 40 years onwards we actually see this kind of adenomas, and from these adenomas can range from few millimeters in size to very large sizes up to about 2 centimeters we can see. Sometimes the adenomas are so small, unless we palpate at thyroid we cannot find them, and they're so slow growing, they're progressively and slow growing. However, we can see large one up to 10 centimeters also. Okay, now this is about the size of adenomas, and all these follicular adenomas, we can see certain all thyroid adenomas, there will be follicle formation will be seen. If there is a more amount of follicle formation, then we call them as follicular. When there are follicles, follicular formation is more, then we call them as follicular adenomas. And all these adenomas clinically, they have well defined margins are present for these adenomas. Again, they are like nodules like growth, they are lump like structures. Normally, the follicular adenomas are of two types. Again, we have which are rich in celluloid material and which are rich in colloid material. Okay. However, the cellular rich follicular adenomas are more commonly seen, and all these follicular adenomas are usually having a well-defined capsule. It is difficult to distinguish between a true adenoma and also an isolated goiter, unless if you don't see this this capsular growth. In well-defined adenomas we have nice capsule. However, in case of your isolated goiters, that encapsulated form is not present, but to look, they are actually clinically are so similar. It is very difficult to distinguish both of these structures. Next, these follicular adenomas have evidence of function is present. That means they secrete hormones, they release a thyroid hormones. However, T3 and T4 are released. Hyper or over secretion of them is not frequently encountered, unlike your other neoplasms. In case of adenoma of thyroid, there is release of hormone. It is functional. However, hyper secretion of these hormones is not usually encountered, and they take up iodine also. Adenomas usually take up iodine. That means that there is a function there. Okay, and in case of radioiodine, uptake is present because they exhibit function. And there is something called as toxic adenoma. Again, in this toxic adenoma, it is actually a part of your toxic nodular goiter, which actually transform into a malignancy. Okay, and usually these follicular adenomas rarely transform into malignancy. Very rarely they can transform into malignancy. If at all they are transforming into malignancies, it is very difficult to identify them. Hence, histopathological investigation of all benign adenomas has to be done to, if it is a follicular, if you are suspecting a follicular adenoma, always it is better to go for histological evidence to exclude if there is any follicular carcinoma, because both follicular adenoma and follicular carcinoma are so clinically, isotopically, and also your cytologically they are very similar. So just FNAC also could not sometimes help you unless you go for a histopathological examination. So FNAB would be a better one. Instead of an open biopsy, you can also go for a core needle biopsy in case of identifying your follicular carcinomas when you're suspecting for a follicular carcinoma. And then follicular adenomas are usually, they have a consistent pattern of follicles is present there. And hence the name itself is a follicular adenoma. Again, based upon this size and degree of follicle formation, they are again classified into embryonal type, into fetal type, and also simple type. In the fetal type, you see this microfollicular structures. The follicles are even smaller in case of your fetal follicular adenomas. And then we have something called as Hurthle cell adenoma. It is again in between your follicular adenoma and papillary adenoma. This Hurthle cell HURTHLE. These Hurthle cell adenomas are also called as oxyphil adenomas. It is actually a variant of your follicular adenoma. These have these are actually a metaplastic thyroid epithelium, which is found pathologically in actually pathological conditions of your thyroid. Okay, this is nothing but your Hurthle cell adenoma. The next one which we have in case of benign adenomas is again your papillary adenoma. The name papillary because it shows papillary process. Like your follicular adenoma, how we have follicular type of cells predominantly present, here we have a papillary type of cells are present, papillary process are present. And one important thing about this papillary adenomas are they are rarely benign. If you are suspecting a papillary adenoma, always think it could be a carcinoma. Work in a way that it could be a papillary carcinoma, so that we can avoid missing out that part of diagnosis there. Okay, rarely papillary adenomas are benign. Most of them turn into papillary carcinomas when we actually do a biopsy and test histologically. If we are suspecting a papillary carcinoma, then we have this it will not be encapsulated, primary thing. Second thing is we can mostly see invasion, capsular invasion, and also angio invasion in case of your papillary carcinomas. If it is only a papillary adenoma, it would be a nice well encapsulated lesion associated with all other benign features with it. Okay, and then the clinical features of benign tumors, as we all know, there will be slow growing masses of the neck. Usually they will be painless, and they have a well encapsulated structure. The lymph nodes are usually not involved, and if we actually palpate, they can be usually greater than it should be greater than 1 centimeter for palpation. And as I told, lymph nodes are usually not involved. If at all there is a bleeding inside the tumor, only then patient usually feels pain. Otherwise, patient usually will not have any pain, and most of the benign tumors are usually painless. And how do we identify them? How do we actually diagnose them? These benign tumors, we go ahead with thyroid function test. Usually, as I told you, they are functional, so the thyroid levels, the thyroid function test also would be little abnormal. We can go for an ultrasound investigation. However, the ultrasound investigation can only give us a clue whether it is a cystic lesion or a solid lesion. Okay, whether it is a solid nodule is present or whether it is a cystic lesion. It will not give us much details into the pathology. And then we can go for radioactive scans. In radioactive scan, it again usually it shows as a hot spot and cold spot. If it is a cold spot, it is highly suspicious. Okay, you have to think if there is a hot spot there, about if 15 to 20% of all hotspot lesions of adenomas can be benign, can be malignant lesions. Okay, so it should not be a hotspot. Then usually they appear as, it should not be a cold spot. Usually it appears as a hotspot lesion. Okay, benign lesions appear hotspot, malignant lesions appear cold spot. I'm repeating again, benign lesions are usually hotspot. If we have a cold spot in a radioiodine scan, then it could be 15 to 20% of these cold spot lesions will be malignant. Okay, and ultrasound will actually give us a detail whether it is a solid lesion or cystic lesion, and we can go for FNAC, that is fine needle aspiration cytology. We can actually see what kind of cells are present there. It will also give us an insight whether there is microinvasion is present or not, I mean angio invasion is present, or if there is any capsular invasion. It will also give us little details of the cellular type also, like whether it is a follicular type or it is a papillary type or a Hürthle cell type of benign tumor. And then when we are talking about CT and MRI, they also give us margins of the lesion and also the extension of the lesion, and also whether it is invading into any other adjacent structures. How do we treat it? Primary treatment is excisional biopsy. Any benign tumor of thyroid has to be treated by excision, and this excision can be either partial the lobectomy has to be done, or we can also do adenoma removal. Once we do this lobectomy, one important thing here is we send a frozen section for biopsy, and until the frozen section comes, I mean it will be done very fast. Before the frozen section comes, by the time the frozen section comes, patient will be anesthetized, still in the phase of anesthesia. If we get a diagnosis that it is a follicular carcinoma or a papillary carcinoma, we do a near total thyroidectomy. Otherwise, we can just leave it like that. We can actually reduce the if it is if the lesion is just a benign lesion, then we actually do that lobectomy and we will leave it like that. As we have done this lobectomy, or after when we thought it was a malignant lesion and we have done a total thyroidectomy, we always have to supplement with thyroid hormones, so that we will not allow TSH to secrete more. We can actually suppress the TSH there by supplying external supply of thyroid. So this is how we treat benign neoplasms of your thyroid gland. Now coming to malignant lesions. As I told, malignancies of thyroid, we have papillary carcinoma, follicular carcinoma, medullary carcinoma, we have anaplastic carcinoma, and we also have lymphomas again there. So this is about your malignant neoplasms. Now again, these malignant neoplasms are classified based upon their origin. If they're originating from the follicular cells, or originating from parafollicular cells, or are they originating from non-thyroid cell origin. Apart from this, these malignant tumors are also classified as well differentiated and undifferentiated. In well differentiated tumors, what will happen is we actually the prognostic value of this differentiated tumor is more than the undifferentiated tumors. Where if they're originating, coming back to the classification, if they're originating from your follicular cells, we again have as differentiated and undifferentiated carcinomas. In differentiated carcinomas, we have papillary carcinomas, we have follicular carcinomas and mixed carcinomas. If it is undifferentiated one, the example for it is anaplastic carcinoma. If it is originating from parafollicular cells, and example for it is medullary carcinoma. If it is not of thyroid cell origin at all, then we have malignant lymphoma, we have sarcomas and metastatic carcinomas. As I already told, the thyroid gland can be a site of other tumors also, for example sarcoma, and it can also be a site of metastasis from distant organs. So metastatic carcinoma can also occur in the thyroid gland. So this is a classification of malignant neoplasms of thyroid gland. Now coming back to the etiology, how these malignancies of thyroid usually occur. The first etiology is iodide deficiency and goitrogenic drugs. Goitrogenic drugs are nothing but this which will have the propensity to develop goiters. In iodine deficiency, especially if it is a long-term iodine deficiency can be seen, in those cases we actually see papillary carcinomas. And accidental irradiation of neck, especially in the childhood, what happens is when the child is exposed to accidental irradiation or especially to the lymph nodes region, etc., in vicinity to the neck, they can also turn into carcinomas of thyroid. And also accidental irradiation of neck even in adults, carcinogenic effect could be either by direct cellular injury or because of your injured cells. This injured cells, what happens, they actually secrete less amount of thyroid, right? When the less amount of thyroid is secreted, then TSH levels are increased, thyroid stimulating hormone level is increased, so it keeps on forcing the thyroid gland to produce more amount of thyroid hormones. So there are some tumors which are TSH dependent. This can lead into that increase in TSH itself could be a carcinogenic in nature. And certain autoimmune disorders can also as a sequel of these autoimmune disorders, thyroid carcinomas can also occur. For example, Hashimoto's thyroiditis, its sequel is nothing but your carcinoma. Okay, this is about the brief etiology how this carcinomas can occur. Now, spread of these thyroid cancers, how they actually spread from the site of origin. First thing is direct invasion. Most of the thyroid carcinomas spread by direct invasion. This direct invasion could be by, for example, by infiltration, and this infiltration could be either by the invasion into the capsule region, that is capsular invasion, or it can also be angio invasion, okay, and invading the adjacent blood vessels. Most commonly, this through infiltration spread of the tumor is usually seen in case of your anaplastic carcinoma. Later, papillary carcinoma also follows the anaplastic carcinoma. The next, lymphatic spread. Almost all thyroid tumors spread by thyroid malignancies spread through lymphatic route. Okay. Sometimes what happens is, before the thyroid carcinoma enlarges in size, the nearest draining lymph nodes usually enlarge. So that rapid spread through lymphatics is usually noted in case of some carcinoma, the carcinomas of your thyroid. Then hematogenous spread is also present, but this hematogenous or blood spread usually it is not very commonly seen, and by this blood spread what happens, distant metastasis can be noted. Distant metastasis in lungs we see, that is pulmonary metastasis can be seen in case of bone, and in case of kidneys can also be seen. This blood spread is usually in case of follicular and also in case of anaplastic carcinoma. And I was talking about the lymphatic spread, right? In the lymphatic spread, as I told you, before your the carcinomatous nodule is being enlarged, we can see the nearest lymph nodes enlargement, right? Sometimes this was earlier termed as lateral aberrant thyroid, because the side of the the lymph nodes which are present adjacent to it are usually enlarged, and we can feel that the nice ovoid to spherical nodule kind of thing adjacent to this. So it could be mistaken as a lateral aberrant thyroid there. So this is nothing but your enlarged lymph node in case of your carcinomas. And then when coming to this papillary carcinoma again, normally the papillary carcinomas are one of the most common one, and this one usually seen in case of about 60 to 70% of all the carcinomas. We have papillary carcinoma, and 80% of thyroid carcinomas in children are usually your papillary carcinomas, and these papillary carcinomas are usually unencapsulated, okay, unlike your benign tumors, these are unencapsulated, and the route of spread is usually through lymphatics. When you are coming to pathology, these cells usually have columnar thyroid cells which are in the form of papillary projections. That is the reason it is papillary carcinoma. We also see the connective tissue vascular stacks attached to these papillary projections. And characteristic Samoma bodies are seen here. Samoma bodies are nothing but sand-like. These Samoma bodies are nothing but your, it is localized deposits of calcium in the connective tissue layer. Samoma bodies are nothing but localized deposits of calcium in the connective tissue. Okay, these are actually called as Samoma bodies, and this tumor is known for its multicentricity, and this is dependent upon the TSH stimulation. More is the TSH thyroid stimulating hormone, more is the growth in the in the size of your tumor. And enlarged lymph nodes in the early stages, what we can see, lymph node metastasis is usually very early. Before the nodule grows in size, the lymph nodes are usually enlarged in these cases. Then coming back to clinical features, age, about 3rd to 4th decades of age is involved. Advancing the age, with advancing age, more is its malignancy feature. If 10 years of age, from 4th decade to 5th decade, the risk of malignancy is more in that. The risk of, the prognosis is again coming down with advancing in age. Usually it is again more frequently seen in females. It is again a slow growing tumor, and slow growing in the sense it starts from very small size, and to grow to bigger size it takes usually some some period of time, and it is an asymptomatic nodule. More is the size, it is less is the prognosis. It is a slow growing one, greater is the size, less it is the prognosis in these cases. And because of the size, what happens is, or increase in the size, it lays pressure especially on the trachea and also the adjacent structures, and it is usually fixed, it is not mobile, and it sometimes it does not move on deglutition also. And distant metastasis is usually seen in case of your papillary carcinomas. And the prognosis is here in case of papillary carcinomas, it is not usually determined by the lymph node metastasis, but it is usually determined by age. Remember, in case of papillary carcinoma, greater is the age, lesser is the prognosis. And recurrence rate is also very high in case of papillary carcinomas. Then coming back to investigations, straight X-ray of the neck usually gives you small specks of calcium. As I already told, psammoma bodies are usually present in case of your papillary carcinoma. And yet in the straight neck X-ray, you can actually see this as small radio-opaque structures. And radioiodine scan, cold nodule is present. As I told you, cold nodule indicates a malignancy. And ultrasonography will actually give us, an insight into whether the tumor is solid or cystic type. Usually it does. It reveals, in case of papillary carcinoma, it really reveals a solid type of tumor. And needle biopsy, and then taking into the cytological or histopathological investigation is usually the gold standard one and is a final diagnostic test. Then coming back to this is a picture showing radioiodine scan, where we can see how it appears on a scan of this. Okay. Then coming to management, usually the management for papillary carcinoma, the primary mode of treatment is surgical excision, and only surgical excision could actually save the patient. If when we are doing surgical excision, entire lobe along with isthmus is removed. When we actually remove the entire lobe along with isthmus, go for a frozen tissue biopsy there. After the frozen tissue biopsy, if we get back a report, okay, when telling that it is a papillary carcinoma, go for near total thyroidectomy. After this near total thyroidectomy, why near total thyroidectomy? Why not we just can remove that lobe? Is because, as I already told you, the tumor has the propensity of multi-centric, right? Because of its multi-centric nature, what we do is we actually do this near total thyroidectomy. Once we have done this near total thyroidectomy, we have to do a suppressive doses of thyroid hormone has to be supplied. So what will we give? We give thyroxine about 0.3 to 0.5 milligrams. We actually give it lifelong to suppress the TSH hormone again. And then other ancillary treatments again we have is radioactive iodine. Radioactive iodine can also be given, but before we give radioactive iodine, surgical excision has to be done. If we remove that bulk of for radioactive iodine to work, we actually have to debulk the tumor size, and external irradiation also will be helpful with radio ablation is actually the treatment of choice, and chemotherapy is also useful, but chemotherapy is not as good as your irradiation. And this chemotherapy, usually the drugs that we give are doxorubicin is the drug of choice. And this is a picture where we can see near total thyroidectomy has been done. A complete thyroid lobes along with isthmus is removed there, and as it is removed, posteriorly we can see parathyroid glands present there. Now coming back to our another carcinoma, another variant is follicular carcinoma. This follicular carcinoma, usually about 50 to 20% of all thyroid carcinomas, are follicular carcinomas. Usually in follicular carcinoma, it is encapsulated. As I told you, the earlier papillary carcinoma, if you remember, it is unencapsulated. But follicular carcinoma is usually encapsulated, and we have crowded follicular cells. And these crowded follicular cells also they form into a lumen. We also have an SNI there. And we have a vesicular nucleus present. We have characteristic vascular invasion and also capsular invasion. These two are characteristic features of carcinoma. However, we don't see much of lymphatic metastasis, and also multicentricity is very rarely seen in this kind of carcinoma. Usually it spreads through blood spread. Hematogenous spread is the most common one seen. It is hematogenous spread to different sites are seen, especially to bone, to lungs, and also to the liver. And variants, coming to variants, we have capsular invasion variant and early vascular invasion. In capsular variant, what happened? It is nicely encapsulated but well differentiated. Because of its well differentiated nature, it cannot be differentiated from benign adenoma. If you remember, I have already told you, a follicular adenoma and follicular carcinoma, clinically, cytologically, and with radioiodine tests, they look almost same unless histopathologically. So because of its well encapsulated nature and well differentiated nature, capsular, the first variety is difficult to differentiate from your adenoma. And we have second variety where early vascular invasion is present and it is very aggressive and also well differentiated tumor. And the third one we have called as Hürthle cell tumor. Hürthle cell tumor is actually different from your follicular carcinoma. It usually occurs bilaterally. Not just one lobe is involved, it usually occurs bilaterally and it metastasizes locally, and high recurrence rate is present in case of this Hürthle cell carcinoma. Coming back to clinical features, usually occurs in older age group, more than 50 years of age group, and from there it usually seen more frequently. And then females have more propensity again. Patients usually gives a long-term history of goiter. They usually have a long-term history of goiter, and suddenly what happens, there could be increase in the size of the goiter, and also hardening, sudden hardening of the goiter could be present in case of this case of follicular carcinoma. And usually they are asymptomatic and slow growing nodule in case of this follicular carcinomas. Distant metastasis is usually seen, so it is more spread through hematogenous. In late cases, what happens, because of increase in size, there could be pain and also invasion into adjacent structures. If it is metastasizing usually to bone, it is usually a osteolytic bone metastasis is commonly seen. And treatment, if it is a low grade carcinoma, then we go for thyroid lobectomy, and near total lobe thyroidectomy is better when we know it is a carcinoma on frozen section. And then this tumor usually responds well to radioiodine, this follicular carcinomas. If at all we know that the lymph nodes have been involved, then we go for radicular neck dissection or dissection of the nodes. And as we have removed the complete thyroid there, that is near total thyroidectomy has been done there, we actually do a suppressive, we actually supplement the patient with suppressive nodes of thyroid hormone, especially the thyroxine one. In case of aggressive kind of follicular carcinoma also, we go for near total thyroidectomy. Opposed to that, we actually give suppressive doses of thyroid hormone. And if the nodes are also being involved, then dissection of the nodes is usually taken care of. Here what happens is the prognosis is usually again dependent again here on nodal involvement. Okay, how many nodes are involved, that could be the prognostic factor again. And we have various adjuvant treatments like L-thyroxine, radioiodine therapy, external irradiation, and chemotherapy. We have various adjuvant treatments like L-thyroxine, radioiodine therapy, external irradiation, and chemotherapy. This radioiodine therapy usually, follicular carcinomas usually respond well for this radioiodine therapy. However, this, one contraindication for this, it is not usually used in case of younger individuals, and when the lesion is, or when the nodule is less than 1.5 centimeters, it is usually contraindicated. And external irradiation with radiofrequency ablation is, one commonly used adjuvant therapy. And chemotherapy is also used, but external irradiation is usually given as a palliative therapy. Okay, for reducing pain, we give this external irradiation. Chemotherapy is not so well accepted like radiation therapy, but chemotherapy can also be given to, again, for palliative therapy, like we give doxorubicin as one of the chemotherapeutic drugs. Now coming to another carcinoma, that is anaplastic carcinoma. Anaplastic carcinoma, it usually occurs, about 10 to 15% of thyroid carcinomas include anaplastic carcinoma. These anaplastic carcinomas usually develop from a pre-existing nodular goiter or from a well-differentiated thyroid carcinoma. This can transform into this kind of anaplastic carcinomas. And anaplastic carcinomas are usually not encapsulated. As it is not encapsulated, what happens? It gets extended. It extends nicely into the adjacent tissues, into adjacent thyroid, and also into the adjacent structures that are present. It gets extend. The cells are usually spindle-shaped cells. We also see small cells or multinucleated cells. mitosis. Mitosis is the pathognomic feature of your anaplastic carcinoma, and these carcinomas, anaplastic carcinomas, are very rapidly growing. They are very, the local invasion is very much seen in these cases. Because of this local invasion, what happens, and the growth which has been rapid, it encroaches onto the adjacent structure, thus causing pressure onto your trachea and esophagus. Okay. About the age group is about greater than 50 years of age. Again, females are most commonly involved. However big the lesion is, it is usually painless. But what happens is, because of its pressure onto the adjacent structures, it becomes painful slowly, and then it is very much fixed to the underlying structures. It is not movable even on deglutition. It encroaches onto the adjacent areas. Because of this encroachment, what happens? Patient, even onto the esophageal and the trachea, patient will have dysphagia, patient will have dyspnea, there will be poor movement on swallowing, and patient will have difficulty in swallowing. Again, patient will feel like there is some kind of lump on the in the throat region. That is because of increased pressure. And we can see lymph node metastasis and also distant metastasis to organs like lungs, liver, and bone is one of the most commonly seen. The tumor is hard in consistency. Okay, this anaplastic carcinoma is usually hard in consistency. When we have come to treatment, needle biopsy or incisional biopsy can be done. Once we know that it is an anaplastic carcinoma, total thyroidectomy has to be done, and we also have to go for neck dissection based upon the nodes involved. In these cases, as I told you, that there will be encroachment into trachea. Patient will have dyspnea, difficulty in breathing. So we go for tracheostomy procedure so that we are bringing down the difficulty in breathing. Before going into tracheostomy, we can also do this needle biopsy and incisional biopsy. Why we do a needle or incisional biopsy? To debulk the thyroid tissue there. When we are debulking the thyroid tissue, what happens? That there will be relief with the pressure is actually relieved there, and hence patient will have the difficulty or discomfort because of pressure. Because of pressure onto the adjacent structures will be relieved when we do a needle biopsy or incisional biopsy, thus debulking the amount of tissue. The final treatment is total thyroidectomy with modified neck dissection. And radioactive iodine is usually not very much effective in this treatment in this case, and external irradiation would be of little importance. Again, if it is given, we give it for palliation or palliative therapy there again. And chemotherapy, again, not very effective, but we can give chemotherapy drugs like adriamycin, chlorambucil, and we give vincristine can also be given. And the final carcinoma, again, of origin from the thyroid, we have medullary carcinoma. This medullary carcinoma is a non-follicular type, as we have discussed. It arises from parafollicular C cells, right? This has a peculiar feature where it secretes calcitonin. It has a familial incidence, and it is usually an autosomal dominant disorder. Usually, these medullary carcinomas are associated with multiple endocrine adenomas, or multiple endocrine neoplasms type 2. Okay, so most commonly associated with pheochromocytoma also. The tumor is usually very small. It is you cannot even palpate it. It can be so small to it can be so large, that is about greater than 10 centimeters of size. Usually they present as single nodules, but if it is of familial variant, then there can be bilateral and also multicentricity can be observed in these cases. Normally, coming to pathological findings, to pathology, they have a solid mass of cells, but these mass of cells are not follicular type, and they are actually they have a pattern of solid mass, and also sometimes we see this presence of amyloid material within the stroma. C-cell hyperplasia is usually seen here. Yes, actually C-cell hyperplasia is known to be a precursor of your medullary carcinoma. We also see other materials like amyloid material, we see thyrocalcitonin granules, and increased mitotic activity is present. Vascular and lymphatic involvement through both routes it usually spreads. If at all we see a bony metastasis, usually it is osteoblastic type. Remember, in case of medullary carcinoma, the bony metastasis is usually osteoblastic type. Coming to clinical features, it can occur from very small child from 2-year-old to 89 years old. Wide range of age group is being involved. Equal sex predilection, And invasive symptoms are usually present here. Invasive symptoms, as I told you, it is actually invasion leading to cervical discomfort. There can be pain, there can be pain that has been radiating to your jaw and ear. There can be hoarseness of voice, that is because of involvement of recurrent laryngeal nerve again. And then patients usually have dysphagia, dyspnea, and the difficulty in swallowing, that they have that lump like feeling again in the throat region. Hoarseness, as I told you, it is because of involvement of recurrent laryngeal nerve. These patients exhibit diarrhea. Why diarrhea? Because there could be increased motility and also impaired water electrolyte imbalance is usually seen in case of this. We have this medullary carcinoma. Cervical lymphadenopathy is usually seen in these cases. Ectopic production of ACTH is one of the pathognomic feature of this medullary carcinomas. Nephrolithes, pheochromocytoma, Cushing syndrome is been associated. Why? Because it is usually associated with men's type 2, and in advanced cases what happens is because of increase in size it can invade into trachea and esophagus. So how do we diagnose it? As I already told, it is secretes, it is from parafollicular C cells, it secretes calcitonin, right? So by radioimmunoassay we can see there is increased serum calcitonin there, and pengastrin stimulation test can be done, and urine catecholamines and their metabolites can be tested to test for pheochromocytoma. This will help us to know that it could be a variant of men's type 2. And then CT scan. In CT scan we can actually see an adrenal gland size, increase in adrenal gland size. And when we are treating it, how do we treat it again? Total thyroidectomy, bilateral neck dissection is required here. Usually do not respond to thyroxine, radioiodine or external irradiation. If we can go ahead with chemotherapy, adriamycin could be our drug of choice. Sometimes subtotal parathyroidectomy is also required. And if pheochromocytoma is been associated with it, then we go for bilateral total adrenalectomy. In case of post-op the care, we should go with replacement with glucocorticoids and mineralocorticoids when we are performing a bilateral total adrenalectomy there again. Next one is malignant lymphoma, which is again of non-thyroid origin. There are actually no special features for it. I mean, it does not show us more amount of clinical features for diagnosing. Accidentally it could it could be an incidental finding, and an FNAC or true cut biopsy can show us that it is a malignant lymphoma. Once we clinically see for clinical evaluation, in case of malignant lymphoma, it is again a rapid growing one. We actually see a large swelling. Because of this large swelling, what happens, there could be tracheal compression. So treatment would be radiotherapy for case of malignant lymphoma. Isthemectomy is used because this isthmusectomy is usually done to relieve tracheal compression. Okay, and part of it could be actually by the time patient comes to us with a large thyroid swelling. In case of a malignant lymphoma, it could be already a disseminated malignant lymphoma. That means patient already had disseminated malignant lymphoma, and finally, not exactly the last one, it need not be a last one, but by the time we see a large thyroid swelling, the lymphoma would have been spread to other body parts also. So this is about malignant lymphoma. So we have seen about various benign and malignant tumors of your thyroid gland, and hope this gives you better insight into it. Thank you.